Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On today's podcast, I'm speaking to Dr. Caroline Taylor, who's the chair of the National Association of Primary Care and a GP in Calderdale in West Yorkshire. The NAPC has been at the forefront of developing the neighbourhood approach to health, and in this conversation, we talk about exactly what a neighbourhood is and how general practice should fit into this model. Caroline explains the benefits of this way of working for GPs and practices, including increased job satisfaction. We also discuss how neighbourhood models could help shift care out of hospitals and into the community. And Caroline highlights the role of the community health and wellbeing worker, a model the NAPC has been involved in rolling out nationally, and explains why this approach is so transformative. And we talk about the potential impact ICB cuts could have on developing neighbourhoods and what GPs can do to get these initiatives going in their local area. I'm delighted to welcome onto the podcast now Dr. Caroline Taylor, who is the chair of the National Association of Primary Care, or the NAPC. Caroline is a GP practising in Calderdale in West Yorkshire and the Calderdale GP clinical lead for mental health, learning disabilities, autism and children and young people. The NAPC has been at the forefront of developing the neighbourhood approach to health, and Caroline is a big advocate of this model, and that's what we're going to talk about today. Thank you so much for coming on the podcast, Caroline.
It's a pleasure. Thank you for having me.
So we're here today to talk about neighbourhoods, but before we start on that, can you just explain a bit about the National Association of Primary Care, or the NAPC, and what it is you do as an organisation if people don't know?
National Association of Primary Care is a not-for-profit organisation. Its prime purpose really is to try and effect transformational change that is patient-centric and reflects the values of the organisation. So we do this in a variety of ways. We have several different programmes that we're running at different times, depending on what's current and what's the most important pieces of work. So we've done population health improvement. We've had a care programme, which is very much for any member of any team across health and care, helping to support them with, I think really it's about delivering or helping them to understand how to re-find the joy of what they were doing at work and do things slightly differently. And that's had a really positive impact, for instance, on retention of staff. We've done care navigation. We have a digital programme. So various different programmes of work going on. And what we do by delivering those pieces of work, rather than a traditional sort of consultancy who would go in, helicopter in, deliver a piece of work and leave again, we very much see all of our programmes as being developmental and iterative. And we go into a place with a programme at a certain level, and then we will deliver it and leave them able to continue that piece of work themselves. But also we will take from each place what we've learned and developed moving forward, so we can then take that to the next place. So it's about spreading good practice, continually evolving and determining what we can do better. And then we have a strong ethos of innovation and moving things forwards, which is usually unpaid. Just that's really a very significant part of the not-for-profit bit, is to be looking at what's the next thing that's going to come along. How do we be ready for that? How do we push things forward? How do we help support small programmes of work that might be going on somewhere else that we think are really powerful? So the Community Health and Wellbeing Workers programme is a really good example of that. It gradually snowballed to being the point where we could actually get a programme up and running in one particular part of the country, and then it snowballed from there, so that we're now nationally leading the programmes of work across everywhere in the country and sort of holding that ring on it all and helping to drive it forward. You know, there's no money in it at all for an APC. It's just that we think it's the right thing to do. And particularly with that one, it's sort of a good example of integrated neighbourhood working is something that NAPC have basically been talking about for 20 odd years now. There's nothing new. The language changes. We were talking about primary care home and had a big programme of work that we called Primary Care Home. Going back to sort of 10 years is when that started and was really going strong. That led to the development of the primary care networks, which has pros and cons to it. So it was a national programme that took on board some of the philosophies of what we thought about primary care home was, in terms of collaboration and working primary care in a different way, but sort of created it into a contract. So maybe not quite what we were anticipating. So in the background, we were continuing really with that primary care home type of work, and supporting primary care networks that were interested in still working in that much wider group than the actual contract dictated. And that gradually morphed into locality working, and then we sort of settled on neighbourhood working as being and integrated neighbourhood teams as being the sort of language that we were using. And so it's quite interesting because now that's the language that's being used nationally. So it's primary care networks and primary care home was a thing that we started, and now we feel like it's coming round again, and we're really hoping that this time we can actually get it to stick in a more cohesive way and more equitably spread across the whole country. So with primary care home, we had 15% and more of the country who had primary care homes, but it's still not the whole country. But then the whole country had primary care networks, but they weren't really exactly the integrated collaborative working models that we envisaged. So now we've got the integrated neighbourhood working model, which we're very clear on, and we are delivering in places across the country very successfully and really ploughing on with. And yet other parts of the country, there's no work at all started on that at all. So we're hoping to see a national spread and maybe something coming out of the 10-year health plan, we hope, that will help promote that way of working.
There is now a bit of a general consensus. I mean, we obviously haven't seen a 10-year health plan yet, but there seems to be a general consensus of everything that's kind of coming out is that neighbourhoods is where everything is heading, and that better working across traditional boundaries will, help improve health and outcomes. But what exactly is your view of what a neighbourhood is, and how does general practice fit into a neighbourhood in those models you're talking about where people are already doing it?
So I think we're very clear in the National Association of Primary Care of how we would define neighbourhoods, and we have been consistent all the way through. So we feel that from a scale point of view, it's about 30 to 50,000 people as population, sometimes bigger, sometimes smaller, but not a huge amount bigger. And the reason for that is that when you're thinking about a neighbourhood, really what we would say is it's anybody working for and with the people that live in those neighbourhoods to help them manage their health and well-being better. And so that's literally everybody from the fire service, the voluntary sector, the person who runs the local football club up at the park, social care teams, it's the community trust from the health service point of view. It's all of those people, but then it's, for us, founded on what has to be the cornerstone, which is GPs and GP practices, because we are the only universal available service for anybody in the country is registered with a GP, can walk in at any time with a problem. And there aren't any other services that you can do that with. You can't even do it with social care. And we have records that we keep of it, and we can analyse and understand. And we already have all the links with all the other organisations, perhaps not to the extent that we would like to see it, but certainly there are links there already. And I think what we envisage with neighbourhood working as being slightly distinct from what's currently going on in its sort of truest form, or perhaps most evolved form, is that you've got all the people that are in that neighbourhood working with those people know each other, not always in detail, but know of each other, know how to contact each other, don't have to go through a formal process to try and work out who they are, because they know, because it's usually around 100 people that will be working professionally, or maybe 150 with that group of size of population. And that's not the number of people that we can all get to know really well, but we can get to know them on some level and recognise names and have that network relationship. So that's why that size is important. And also it's meaningful for the people who live in it. So they don't feel too much of a small cog in a big wheel. They actually know and recognise the team when they're out and about. And, it becomes a bit more of a team that involves the people who live there, not just the people working with them. So that's really where the size comes from. The vision for me about how it works is that when something's going wrong in your life, you don't really want to have to explain it 12 times to 12 different people to try and get to the right person who can actually help you, and wait in between each of those processes. And that, unfortunately, is the system that we have created to a large extent in this country. What we know in certainly GPs do a lot of shortcuts for that. And I think the additional roles have really helped with that. So, the fact that we now have pharmacists and paramedics and physios, occupational therapists, social prescribing link workers, mental health workers all within the PCNs already. So within those neighbourhoods, and part of the team are sort of employed within it, means that we have those relationships that are stepping outside anyway. And then if you look at each of those individuals, they then have a broader network. So the physios will be linking with the physios at the hospital. You've got the paramedics will be linking with other paramedics and other visiting services when they're doing home visits. You've got your pharmacists who know the community pharmacists, the hospital pharmacists, each other. So you've created a bigger network already. So your neighbourhood working is already starting to happen by virtue of the fact that I know how to contact my social prescribing worker without having to fill in a form. I either can just send them a message on my clinical system if I want to, or send them a task, or give them a ring, or whatever it is. And then it sort of spiders out from there. We're taking the person's story, understanding it, talking it with them, shared decision making, so that, what is it that's going to help you? What's the situation you're in at the moment? How can we best help and support you? And then we're directly putting them in contact with those people rather than filling in lots of forms. So it's a seamless process relevant to what the individual needs at that time. We don't want to play ping pong with people. We want to actually help them in the way that makes most sense to them.
What would you say are the benefits of this way of working, the benefits of working as a neighbourhood for GPs and for people who work in general practice? Is it just because of what you described that it makes it easier for you to help patients, or are there any other benefits for practices?
Well, I think it is more efficient, because at the moment, it's not efficient to be filling in lots of forms, and people are on waiting lists for long periods of time to get to the services that they need. And apart from anything else, when people are on waiting lists, whatever they're waiting for, they inevitably will come back to the GP several times in the meantime. So from a GP's point of view, it has a workload implication. But more importantly, really, it's very frustrating for anybody who's trying to help and support an individual to not be able to actually get on and see that help and support is actually happening for them. So if we are working in that neighbourhood working way, we are immediately making sure that the person is getting what they need straight away, that we're having a conversation and making sure that the person that's going to support them understands and knows a bit about them. And individual doesn't have to repeat the story, but also I don't have to fill in a complex referral form. The person who's going to see them doesn't have to then do a big discharge plan, because we're passing them around as they need to be passed around and supporting them where they need to be supported. As a GP particularly, I've been working this way for a long time now, as far as I can within the constraints of the current system. And it's so much more satisfying. It's much more rewarding. It allows you to return to doing what we went into the profession for, which is to help people. If that's not too highfalutin and altruistic sounding, it isn't about that. We find it very rewarding, I think. And if we can't do that, then it's very frustrating. But as soon as you can, you find yourself excited and activated and keen to get to work again. Just being able to take a little bit more control of the way that you're working and do it in a way that feels right for you and right for the patient is so rewarding, and makes you want to get up and go to work in the morning, and makes the long hours and all the other irritations and frustrations about it less so. So the more we can do this neighbourhood working, the better it is for individuals, but also I believe absolutely firmly it's much better for the people working in the system as well.
We've talked about the fact that neighbourhoods are probably going to be a big part of the 10-year plan. Do you think the 10-year plan needs to be quite prescriptive about what neighbourhoods are and how they work? Or is it really important that local areas are given tons of flexibility so they can set it up how they think it should best be done?
Absolutely the latter.
Right.
Because there is no one size fits all. I've already described how some places in the country are already working in ways like this. As far as I'm aware, there is nobody that's got it perfect. And NAPC is working with, some of the people who are really at the cutting edge of pushing forwards and really working towards the neighbourhood working model. Having it fully expanded is not something that is really happening yet for lots of different reasons. So one place might be doing one element of it and another place another one. In one place, there may be a primary care network that's really driving forwards and forwards thinking, but another one, it might be a community trust that's actually in a better position to sort of lead the work. And I think as long as GPs and the practices, because of that universal access that people have to it, as long as they are the cornerstone and deeply rooted within the neighbourhood, it doesn't really matter who's in the right position to lead it. So we don't want people to be dictating who should be leading it. I don't think that's the right thing to be. Go where the energy is, don't you? That's how you get the best transformational change. And also the needs of different populations are very different. You know, population health improvement is really important to look at what your particular area is. And again, with a 30 to 50,000 population, you'll be able to see what the need is much more specifically and target initially the groups of people who you think are going to benefit the most from it. So you can start small and then expand out from it. But that's going to be different in all different parts of the country. And GPs are perfectly positioned for understanding their population. And actually, so are the rest of the workforce that are working around in that neighbourhood, because they've been working with the same people. So the more we align social care geographies so the team is working within that neighbourhood, the better they understand their patients, the more relationships they have with us, the more we can support the voluntary sector organisations that are, you know, small and often struggling in those neighbourhoods, but the more we can signpost and encourage and help people to use those services, the better they will be able to support themselves, and the better then they can help the individuals they're working with. So it becomes tailor-made to the needs of each individual place. And if it's prescriptive, we're not going to get anywhere. Plus, staffing's different in different places. Some places can recruit one role more easily than others, or historically have just developed more of one than another. And what we would say at National Association of Primary Care is that you look at your neighbourhoods and you look at the functions you need to have met within that neighbourhood in order to meet the health and wellbeing needs for that population. And then you look at the people that you've already got working there, and then you work out how the two marry together. And there will be some gaps, and then you can fill those gaps. So yeah, no one size fits all. We really hope that it's incentivised to deliver the care in a way that gives the right outcomes, and that it's outcomes focused rather than tick box focused. And, you know, you can say that you've got an integrated neighbourhood team because you've got this set of people working in a particular way. That isn't it, the point of it at all. It's about delivering the right outcomes for people and working in the right way to make sense and make the best use of what you've got and meet the needs of your population in the best way.
Do you think longer term this could potentially, you know, change how general practice operates, maybe change how funding works in general practice? Do you think that's likely?
Funding is a very tricky one, because the obvious thing really would be for funding to follow the individual, wouldn't it? That sounds easy, but when you look at how diverse that is from where we are at the moment, there's a big old journey to get to that point. Yeah. But there's an awful lot of places now that are pooling their resources, shall we say, and creating pooled budgets around patients or pooled budgets around practices or what have you, so that they're sorting out some of that funding issue. And it would be nice to think there was a way of resolving it centrally, but I fear that, again, if that was overly prescriptive, like with the primary care homes, we're doing some fantastic collaborative, innovative, integrated working, and then it became contractualized by the primary care network, which is a contract, not really a way of working. And whilst there were still some excellent elements of that, and there were still lots of PCNs doing some really good stuff, it did take the positives out of it. So I don't think it's about focusing on the finances. I think it is much more about the way that actually everybody's working and delivering their work. But in terms of, is that the way that we will be working completely? I would love to think so, because I think if we want to create a sustainable National Health Service, we need to be shifting work out of hospitals, which are hugely expensive and wasteful of resources. We need to be thinking about preventing illness and keeping people well and supporting them to live their happy, healthy, full lives, not supporting them when they're critically ill in hospital. Obviously, we need to do that bit as well. But if we can prevent illness and help people to live healthy lifestyles and, you know, support themselves and then support them within the neighbourhood, then we're really shifting everything to the left of the curve of illness, away from the right-hand side where people are all in hospital, which is much more sustainable and a cheaper way of running things. And, you know, that's the only way the NHS is going to really survive, I believe, because we can't keep taking more and more resource and throwing it at the illest section of the population. And we would clearly want to know that if we are taken ill, that we will be looked after in the best possible way. Can't really think that anybody would say, yes, I'd much rather wait and have the money spent on me in hospital and not have it spent on keeping me well and at home. And it's clearly cheaper. We know that if you spend £1 in the community, you'll save £14 for the system compared to where it would be, you know, if you were spending it in the hospital. Neighbourhood working allows us to completely move everything into the neighbourhoods away from the hospitals and make financial sense. Plus, I think we're in a fantastic, better environment for making these changes actually work than we have been in the past. Not just because there's a lot of better relationships formed and, a lot of groundwork has been happening in a lot of places in terms of starting to know the people they're working with and the neighbourhood starting to grow, but also we've got digital solutions that are revolutionising care and that need to be brought online much more wholesale. And even if you just take the NHS app, it's just not being used to its best effect by the majority of people in this country. And the more we can promote and develop the app so that people have in their pockets a way of looking at their own healthcare, being able to share it with other people, then that's a really powerful tool for people taking control of their own lives and having their own bit. And there's so many instances of apps and tools and all sorts of things that help us to deliver healthcare better.
You mentioned hospitals a bit there, and obviously the neighbourhood thing is very central to this idea of moving care out of hospitals and into the community. Where do hospitals fit in the neighbourhood systems that you're working with that are a bit more advanced? What's the role of the hospital? What do they have to do? Is it important that they are part of the neighbourhood as well?
They're absolutely a critical part, and they should be a partner at the table right from the outset, and in the neighbourhood sort of working effectively around the table right from the beginning. But if you were to actually imagine how a neighbourhood would work properly from an individual's point of view, I try not to talk about patients because if we're going to prevent illness, then you're not a patient, are you? If you do see your GP and they feel that you need to be seen by a specialist, or you need a specialist opinion at the very least, what neighbourhood working and that whole bit about moving from the hospital to the community, you don't have an outpatient department at the hospital anymore, except for very few things where you really do need to be going and actually be being seen in a particular place for a particular set of reasons. The majority of the time, it's be done in the community, in your neighbourhood.
Yeah.
The consultants won't work in the hospitals anymore. They will work in the community, largely, and only go to the hospitals when there's something they need to specifically see you there for. That makes so much more sense. The consultant is travelling once rather than 20 patients travelling to the hospital for them. There's so many levels that it makes absolute sense for. And it's also much less scary to go around the corner to your GP practice than it is to go to the hospital. It's less expensive, it's less scary, it's better for the environment, the list goes on. But it's also moving those consultants into the team so they become part of the team. So they will know the people they're working with. So they will become part of that bit. So when they see the person, and it will hopefully demedicalise that model a little bit. So when you see a surgeon, they don't always feel that they need to operate on you. They will be thinking more about what are the other things that they could be suggesting, because all they have to do is ask the receptionist to link them up with, or even better, make the phone call themselves and link you in with the social prescribing network or the social worker, or signpost you to the voluntary sector organisation, whatever it is, let's get the consultants absolutely part of that. And that isn't just physical health, it's the same for mental health services. And I think they are already more rooted in the community anyway. That is integral to us being able to deliver the neighbourhood working model better.
Are there any places that are actually really doing this, or is this just more still a bit aspiration to get to that point?
It is starting. Again, it's, much further on in some places. Another one, I would say, when you go to a particular, even if you go to a hospital where there's a lot of it happening, or will be happening more in some departments than in others. And it's partly about leadership and, who has the vision and sees it and is dynamic and wants to push forwards with that. So there's always people who are early to adopt anything new and then people who are a bit slower to adopt it. But it is absolutely happening. And it has been happening for a very long time. Neighbourhood working is not a new thing. All clinicians can give examples of things that have worked, but often it's done as a bolt-on service, or I talk about bolt-on-itis and pilotitis. We just do a pilot, we do it, and it works for 2 years because that's when the funding was. And it was great, but we didn't quite evidence it in the way that the accountants want us to evidence it. So it fizzles and it doesn't happen anymore. And I can go back, I think it's well over 10 years, probably a lot longer. In my own GP practice, North Halifax, we had the community, paediatricians came and did their clinics in the community. It was great. Everybody absolutely loved it, but it was a pilot. And actually the funding required was so minimal. I don't even think it was particularly a funding issue. It was more that the pathway hadn't been changed enough and the philosophy almost too radical at the time. Whereas I think now, that sort of snowball effect of things, it takes a long time, doesn't it, to get the snowball started. You were there with a tiny bit of snow, aren't you? Trying to get it to stick together and trying to get the next bit from the ground to stick to it. And then suddenly it takes off and it starts to snowball in a better way. And I think that's where we're up to now, is that, people can see it. And what we're really hoping is that snowball will grow and that the 10-year health plan will facilitate and encourage that, but also not dictate how big your snowball is or where you need to roll it or who should be involved in rolling it.
Well, you mentioned earlier the community health and wellbeing workers, which I know the NAPC has been very involved with trying to get that rolled out nationally. I mean, we actually did a rerun of a podcast episode we did a couple of years ago with the people who kind of started that project in Westminster. Why do you think that model is so transformative?
The community health and wellbeing workers, I mean, they're the most joyful people I've ever met in terms of health and care delivery. They all absolutely love their job. Despite the fact it's a relatively new role, the majority of them stay in it once they've found it, and they possibly can. Community health and wellbeing worker is rooted in a community, usually one that they live in, so they already know and are known in that community, and they know what the services are and what's available. But they look after about 150 households that are all geographically connected. So in Westminster, they're in tower blocks, for instance. So it's, particular tower blocks. In Calderdale was literally postcodes. It is that geography. And the community health and wellbeing worker, the idea is that they proactively knock on doors initially, and they'll send letters and they'll make phone calls and what have you to try and encourage people to engage with them. And once they've formed a relationship and they're starting to understand how they can best slot into and help that individual, they will make sure they knock on the door for at least, or contact that person at least once a month. But when there's a particular need, they can give an awful lot more time to an individual because their time isn't too prescriptively allocated to different things. And they get to know everybody that's in that little group of people's world. And that includes the social workers, it includes hospital consultants, it includes GPs, it includes policemen, it includes the people who support them from an employment point of view. All of the community initiatives that are going on, whatever it is, they know it all. And they are so determined to get exactly what that person needs. In the best of ways, they don't respect the boundaries that the NHS tries to put in, or that Health and Care tries to put in to stop people going from one place to another. They just get on and absolutely support that person. Primarily at the moment, we are focusing community health and wellbeing workers on the most deprived sections of the population, because we feel there's a lot of unmet needs there. And a lot of the people they're engaging with are people who do not ever contact any services. They have a big thing about anything from the system. So there's a really big uphill battle to climb. But then once they've formed that relationship, they're transforming lives amazingly, because they are sorting out benefits and helping people get furniture and pay their rent, and helping them to go and approach their doctor and find that actually they've got high blood pressure and they need some support to manage that. They're supporting them go to cancer screening services and have their immunisations. And this is a model that's been going in Brazil for over 30 years, really successfully. So we know that the number is about right. We know the population is about right for the individual worker to do it. They all support each other. They have managers who help to support them. But essentially, it's about them meeting the needs of those individuals within their little patch. And that's what we're talking about with neighbourhood working. It's just that will be on a 30 to 50,000 person patch. So it's a bigger scale up of it, but it's in the same thing of not needing a piece of paper to refer people along and knowing everybody and being able to get the right people, the right services at the right time.
There's been quite a lot of speculation that this community health and wellbeing worker will be mentioned in the 10-year plan. What would need to happen to make something like that roll out on a national basis? It is a national programme in Brazil, isn't it?
Yeah.
What would need to be in place to make this work across the whole of England?
There's a number of things. I mean, one of the big advantages, I think, of community health and wellbeing workers is that when you first come into becoming a community health and wellbeing worker, there's not a huge raft of qualifications that you need. You don't have to spend, 5 years training or anything else. It's about finding the right person, the right type of person to do it. So we're bringing in a whole new raft of people into a health and care system that is struggling to recruit and retain the right skill sets. So we're bringing new people in, which is a really good thing. But it's funding it is difficult because, you were talking earlier about the funding and how do we actually do that bit. So one of the issues we have is that in the short term, often community health and wellbeing workers will be creating work before they're saving it. We've got the research and the evidence now, particularly from places like Westminster, that have been going for longer with the community health and wellbeing workers, really compelling improvements in those individuals' needs. But it doesn't fit any one person's budget to pay for them in the first instance. And this is part of the issue with illness to prevention shift that Wes Streeting wants us to do, is you need to put some resource in. We know £1 saves 14 if you're spending it in the community compared to the rest of the system, but you're still going to spend the pound before you're going to save the 14. And that is the part of the issue, I think. I think we would actually need funding to do it on a bigger scale so that we can actually really prove the value on a big scale and show how meaningful it is. And then it will become a big rollout of a programme. But if we don't get that, I think at least if neighbourhood working is becoming a big thing, and that is the way that we're working, then I think the community health and wellbeing workers are a really clear way to meet some health inequities and to deliver that neighbourhood working in those groups of patient or people that are really most at need. So it needs some clear funding, almost a stamp of approval that this is a really good way of spending your money. It's a very cheap programme to run for any place or PCN. We've got everything from ICSs right the way down to GP practices who have their own community health and wellbeing workers because they recognise the need and see the value of it and the impact on the individuals.
Just to be clear, those community health and wellbeing workers in all of the projects that the NAPC has been involved in, they are quite closely linked to the GP practice. They were in the Westminster one, the people I've spoken to in Westminster, but that's the same in all the other ones, is it as well? Is that important for that model?
The key to success is that they are linked in, not just that the community health and wellbeing workers are known by the reception staff and the doctors. They need to be recorded within the medical record in some way, shape or form. And there's lots of different ways of that happening. So some places, community health and wellbeing workers actually use the clinical system to record stuff.
Right.
Other places, it's simply that it's recorded on the clinical system for that person. They have a community health and wellbeing worker, and that's enough, because then it means that everybody knows that there's a particular person that's almost like a care navigator or care coordinator, but with bells on. It's that proactive bit that you don't have to be referred to a community health and wellbeing worker. You just have it because of where you live, even if you don't think you need one or want one. We know that people take time to build the relationships and start to trust the community health and wellbeing workers.
One thing I did want to ask you about before we finish is about, obviously, ICBs, integrated care boards, are facing, huge cuts now across the next 6 months, possibly even less. How do you think that's going to impact on developing neighbourhoods? Is it going to have a negative impact on the government's ability to deliver on this, do you think?
I think it depends on how it's done, and I don't think we know yet how it's going to be done.
Right.
The initial vision for how integrated care systems would work, the intention was for them to work in this kind of integrated neighbourhood kind of way, but on a sort of a larger footprint, and then reaching into to places and then into localities. So I think it was intended that happened. But I think, unfortunately, there's been a little bit of an element of, becoming an industry in itself. And I think that's what the government is trying to correct. The ways of doing it, very, very difficult to unpick something so rapidly that's evolved and is performing an extremely useful, effective function in a lot of places, but isn't universally doing so. And I guess if we take it into the strategic place, which is where the government say they want to take them into strategic commissioning, although quite what they mean by that, I don't think any of us really understand. They're asking providers then to step up and do more collaboratively. It shouldn't make a difference, because your neighbourhood is all of those people. It's not relying on commissioners to manage it. And if it were, you're not going to get effective neighbourhood working anyway. I've said, I think GP practices are the cornerstones of it, but it can be a mental health trust or a community trust. It can be anywhere that's actually leading the piece. It's about the collaboration and the working together and the relationships that are formed. And so hard for all the people. I mean, I include myself because I'm working for West Yorkshire ICS in my mental health role. So, very, very hard for all of us trying to work out how we make that radical change. And we still don't really know, have felt like really important and valuable roles are going to be met in a different way. But if we fast forward 12 months, let's hope it has been worked through in a meaningful fashion, particularly for the individuals affected with working within the ICSs. But there's so many places that have got a lot of neighbourhood working happening already. I don't think it shouldn't be derailed by it. And I don't think the intention is to do so. But I really think that we're quite a long way off yet, knowing exactly how it's going to play out. But like I say, I think the important thing is it's about neighbourhood working is about teams of people becoming a team and feeling part of a team and working with and for the people that live in that place. And that isn't dependent purely on commissioners. It's not something that can be commissioned.
If there's someone listening to this who is working in an area where neighbourhoods are very early on in their days and it's only just kind of starting and, you know, feel like they're going to a million meetings about a neighbourhood, what do you need to do to really get it going and making a success? What advice would you give to a GP in that situation?
For any individual person who's working in those sorts of systems and can see the benefits of neighbourhood working, get going. Just start somewhere. Neighbourhood working is about working with other people who work in your neighbourhood. You don't have to suddenly know everything about everything. Even if you just start to reach out and actually pick up the phone rather than making a referral sometimes, and be more curious about the people who are out there and can help. So be curious about the community groups down the road and what happens at the library and at the local leisure centre. You know, be curious about the social workers who are working with your patients. Be curious about the schools that are in your patch. Reach out, ask questions, because you will very quickly find like-minded people who want to start to do things differently. And also do some population health improvement type stuff. So look at the evidence, find out which sections of your population within your practice are perhaps most at need. And actually, we're not doing population health improvement at all universally or effectively at the moment. So you can pretty much pick anybody who's got a mental health or emotional well-being, respiratory, you know, there's a whole list of simple things that, you know, pick one of them and you don't even need to go to the data. You're going to be picking the right population. Pick a chunk of those that you can manage differently and do something different for them, which involves working with somebody else within your neighbourhood. And suddenly you're doing neighbourhood working. That's what it's about. And it will make you want to get up in the mornings and go to work a lot more than you do at the moment. That I can say.
That's really good advice. I mean, that's a really positive place to leave it on. Really, thank you very much, Caroline. It's been really great talking to you. It's, you know, it's quite inspiring that maybe there is a positive future at the end of this, hopefully, if people can get this off the ground.
Thank you, Emma. It's been a pleasure talking to you today.
Well, that's it for this week. Thanks again to Caroline and thank you for listening. I'll be back next week for our regular review of the key news affecting general practice, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news and access lots of other resources on our website at GPonline.com.